A very, very, very warm welcome to every one of the dignitaries over here, specifically from the country as well as our international faculty over here, Professor Sarasis. A very warm welcome to you, sir, for also giving us the time and privilege to be here in this particular virtual meet, though. And I'm sure that with your experience and rich academic that you have, you will be able to share a lot of pearls of wisdom with us, with all of us over here. And I'm sure we all will have a very, very good interactive exchange of ideas on the shockwave technology and its ever expanding envelope of indications. So with this said, I would like to now start the proceedings with the permission of the chair and also the moderator. I would first start with a small presentation of just letting what we are as a company and the strides that we have made in a short period of time. Thanks to all for your support that this has been made possible. So, with your kind permission,
Yeah.
thank you. So, so this is again a privilege to be a part of this masterclass, which we normally have it, on periodic intervals to keep refreshing ourselves, to keep sharpening ourselves in terms of whatever we need to know in our craft. And so this culture masterclass is, which is basically going to be taking us today, this evening, with a lot of dignitaries over here. First of all, as I said, we're very privileged to have our international faculty, which is Professor Sarasis. He comes from the NIHR research, and of course, he's Professor of Vascular Surgery, Vascular and Endovascular Surgeon from UK. And we really look forward to a lot of further wisdom from him on how they use over there the IVL, that is shockwave. We have also a chairpersons, Dr. Raghuram Shekhar, basically the HOD for vascular surgery in the most prestigious hospital in Bombay, that is Kokilaben Ambani Hospital. I've had also always the pleasure of knowing Dr. Raghuram Shekhar and also supporting on cases in IVL. I've had the pleasure of doing that. So it's always a privilege to have him with us. And of course, Dr. Brigadier Satish Chandra Mishra ji, this case with him for Shockwave. So it's always a pleasure. So welcome you, sir, to again know from your side on the pearls of wisdom for Shockwave. And of course, it's always a very, very exciting evening to have Dr. Virendra Shoran with if the word is impossible, that doesn't stand for him. So this is something which you will see in the plethora of cases and the kind of discussion that he imparts to this particular masterclass. So welcome, sir, Dr. Virendra Shoran, sir. We also have Dr. Anoop, basically from the Aster. And of course, I will leave it also to the moderators in order to kind of introduce later on each one of them with the proper credentials. Dr. Abhishek Bansal from New Delhi, from the Akash Hospital. Dr. Mohammed Zubair from Max Hospital, Nagpur. Welcome, sir. Welcome, Dr. Abhishek Bansal. And Dr. Pawan B.K. Again from Bangalore, from Aster. And we also have a rich panelist panel over here with Dr. Bhavin Ram, basically from Hyderabad, from the Yashoda Group, the esteemed hospital. And we have Dr. Venkatesh Bulinini from Hyderabad again. So this is a great blend of wisdom, experience, youth. And I'm sure that this is going to be one of the best kind of discussions that we're going to be having. So I'll just roll on to introduce the Master of Ceremonies for this evening, Dr. Prashant Sarda. Before that, this is the flow of the program that we're going to be having. And also I will now just put a little perspective on who we are, what we are doing, and of course, seek your blessings. So basically, Translumina is a leading manufacturer and distributor of intervention cardiology and vascular devices. We are the leading cardiovascular device company in India, and I'm sure it's a pleasure to inform in this particular August forum that we are the second largest stent player and domestic leader in India. This is a pleasure for us to kind of, have your blessings to make this possible for us. And we have close to about 18.4% stents volume market share. We are the only second company as far as the total companies are concerned, but we are the number one company in the country as far as domestic companies are concerned for stents in the coronary. We have extensive network coverage, which has all made it possible. As I said, with all of you contributing to make this possible for us, we've tried to access each and every cath lab that we can. So we are closer to you, and we have a strong fleet of 100 plus sales team members. We have well diversified portfolios, and I will just talk about that in a moment. We have everything that you could ask for getting kind of, the access to your patients for each of the devices. We have strong partnership record, and this I'm going to be talking about in a while. We also have global sales presence, and I'm sure that we in India would be very proud to know that we have a global footprint in more than 50 plus countries, and also a very, very robust sales team. We have strong clinical heritage, and we are the only company in India to have 10 years safety data, efficacy data, RCTs on 2 stent platforms, and ongoing studies with nearly about 9,000 patients targeted for various clinical programs that we believe are the backbone of any company to keep the momentum going. We have reputed global affiliations and long-term collaboration with German Heart Center, which is basically the backbone of every device, especially in the coronaries that we have in coronary stents. This is something which is a very, very cherished partnership for us. We have the product journey expertise to go to market to make sure that we are able to get the products to you as early as it is in global environment, available in global environment, and we don't lag behind. This is something which is, I'm sure that you will be feeling very proud when you see that we have a robust manufacturing core, and this is close to about 5 manufacturing plants that we are having in India alone, but also in Germany and also in Amsterdam. We have fully integrated manufacturing capability, in-house capabilities for the drug-coated balloons, PTCA balloons, DES, and also the stent delivery system catheters. We have a strong clinical presence in terms of the team that we carry, so as to make sure that we have the cutting edge all the time. And we have established manufacturing facility with a focus on structural heart products, which we have, of course, the facility being set up now in Vizag, and, more news to come on this. As I said, we have a very robust organization, which makes possible that you have the best that you can ask for access, for assessing with the IVIS imaging and options, and we have for preparing the lesion, which is shockwave, which of course is the point of discussion today. And we also have CIS Medical, the Open NC, the Optima NC, Kanika, and boosting catheters. And of course, our legacy is basically in the coronary stents with Yukon Choice, VivoSR, both of them having 10-year RCTs, as I mentioned. And we also have some of the most exciting DCBs now on the horizon. This is, of course, right now in coronary space, Protege. And this is something which is absolutely different from the conventional DCBs that one has known for a long time. We are also having partnership with Medinol from Israel. And we sell in the international markets, as I said, with 50-odd footprints in various countries. Now, it's my honor and pleasure to introduce the moderator for this evening, the Master of Ceremonies, Dr. Prashant Sarda. Very young, but very dynamic, and at the same time, the kind of cases that they do in a place like Dehradun, and if I may call from what he told us, is the diabetes capital of the country. So Dr. Prashant Sarda, very warm welcome to you, and we are sure that you will impart to us fantastic academic experiences and your experiences with Shockwave in the cases that you have been doing regularly and frequently. So he's an expert in vascular and oncological interventions, including complex image-guided procedures and endovascular therapies, and internationally trained with fellowships in South Korea and also advanced taste specialization. He has led and contributed to landmark procedures, including Uttarakhand's first fenestrated EVAR for complex aortic aneurysm, and he's a national faculty in the ISVIR with active participation in conferences, research, and academic training programs. And he's also been recognized with Excellence in Patient-Centered Care Award 2026 for clinical outcomes and patient-focused innovation. Having said this, I would like to hand over to Dr. Sarda. Dr. Sarda, if in case your slides are not running, I can run these particular slides and you can open the meeting as well as also honor our international faculty and all the other guests over here. Dr. Sarda? Hello, Dr. Sarda, are you there?
Yes, he's here, but we can't hear you, Dr. Sarda. Yes.
Can
we
you
can
hear
see
me
you
now?
Yes, sir, absolutely.
Yes, sir, we can hear you.
Yeah, I'm so sorry because of the network and all. So we are starting meeting, and we are pleased to, and like it's a great honor to have Professor Sarasit with us. So Sir doesn't need an introduction, and he is international leader in complex peripheral endovascular revascularizations with strong focus on the limb salvage. He's the chief investigator of multiple national and principal investigator in multiple international clinical trials, multiple publications, and he is one of our like what I can say, like I have seen Sir's work, and like I have heard about his work, and it's wonderful and it's inspiring because of this. So, with the permission of our chairperson, we can start with the meeting. So, the first topic is how IVL moved from a not an option to first choice for PAD calcified lesions in my practice by Sir. So, as we all know, in my practice also, I can see like IVL has now become a first choice if it's a calcified atherosclerotic disease, and it's really a good thing, and like very good recanalization and long-term patencies are very high. So let's start with the topic. Sir, kindly enlighten us with your experiences.
Great. Thank you very much, everyone, both for the invite and the introduction. I'm going to share my screen. So I'll share my entire screen. It is a bit difficult to look at the cameras whilst I'm sharing. So if you would like to stop me at some point, please do stop me, just say something, and then I can answer your question, or we can take questions later.
I think we can take the questions later.
Brilliant, excellent. So I'm Thanos Soratis. I'm a vascular surgeon. The vast majority of my practice is endovascular treatment. I would say about 98%. And I offer lots of peripheral artery disease or PAD treatments, mostly for people with CLTI. Most of the vascular pathology that we see right now in the UK and across Europe relates to chronic limb-threatening ischemia, CLTI. And I'm based in a very busy unit. It's in Leicester, which is north of London in the UK. We've been known for many years because of our academic background. With my team, I'm running a number of randomized controlled trials around peripheral artery disease, and we've got a big program relating to CLTI treatments. What I'm going to try and do over the next few minutes is present you how and why we've increased our use of IVL, intravascular lithotripsy, especially in femoral popliteal disease. And femoral popliteal or FEMPOP disease is the predominant anatomy that we see in patients with both CLTI and claudication, even though we do treat mostly people with CLTI in the UK. These are my disclosures, just to say that I'm the NIHR Professor of Vascular Surgery. The NIHR is the National Institute for Health Research, and I lead a number of studies relating both to PAD and other disease areas. Now let's go back to basics. What is the problem if you've got calcified arteries in someone who's got CLTI or claudication when you're trying to treat their arteries? From an endovascular point of view, the problem is that if you've got a calcified artery, you're far more likely to cause a dissection perforate, embolize, and you're far more likely to need a stent. And stents are not great because they might lead to instant stenoses, or they might develop an occlusion, and these are very difficult and very expensive to treat. Then, when you've got loss of calcium in your common femoral artery, endovascular options are far more difficult because you might jail the profunda, you might jeopardize future access if you fracture the calcium and you subsequently need to use a stent. And you might cause problems with regards to the origin of the SFA and the origin of the profunda, etc. Then when it comes to open surgery like bypasses, clearly a calcified artery is not very easy to suture, and patency of the bypass will be inferior. So calcified arteries are not great, both for open, but most importantly for endovascular procedures. Intravascular lithotripsy has been developed in the last 15 years or so in order to address this specific problem. And the specific components or the specific issues that are addressed by shockwave IVL are the following. First of all, is a good mode of vessel prep or vessel preparation in this context, because you don't need necessarily to perform a pre-dilatation before you place your IVL catheter in the lesion. So you can use it as your primary vessel prep tool. You don't need a filter, and you only inflate the balloon at a very low atmospheric pressure, in between 2 to 4 atmospheres. Also, there's a number of studies now, even randomized controlled trials, showing that if you use IVL in calcified arteries, regardless of the exact anatomy, you're more likely to not need a stent and therefore avoid all the implications and complications that come with stenting. You decrease your dissection risk, and then you decrease your peripheral embolization risk, especially if you compare IVL to atherectomy, which was the more traditional vessel preparation tool that we had been using for a number of years for very calcified arteries in the lower limbs. How does shockwave actually work? You cross your lesion with a wire, and I would say that it's probably wise to do your best in order to cross your lesion, your calcified lesion, inside the lumen. So intraluminal crossing is what I always try and do. And if you can't cross in an antegrade manner intraluminally, increasingly I will go retrograde and again try and remain inside the lumen, because then the delivery of the energy is better. And if you do need to stent, your stent deployment will be more optimal. So once you cross the lesion, and as I said, try and cross intraluminal. If you can't, try retrograde. If you can't cross intraluminal again, of course, then you're left with no choice. You cross in a subintimal plane. So you cross the lesion, you place the shockwave catheter. It handles the same as an angioplasty balloon. And then you inflate at 2 to 4 atmospheres, and you deliver your energy. So the energy, what it does, the shock waves practically create a number of microfractures after they get absorbed by the calcified component of the plaque. And that's very important, because if you think about it, all of the calcium will be under the endothelium. And therefore, because the energy is absorbed only by the subendothelial calcified component of the plaque, you don't get dissections and you don't get emboli, because nothing happens inside the lumen. It all happens below the endothelium. So once you create those microfragments, in principle, in theory, if you think about it, then the artery becomes more compliant. because the microcracks mean that the artery wall is now a bit more flexible. After that, you can take your catheter out and you can perform a plain balloon angioplasty, or you can perform some other type of treatment, deliver a DCB, for example, or a drug-eluting stent, or whatever other type of treatment you wish to deliver. You don't necessarily always have to do that. You don't necessarily always have to use a DCB or a drug-eluting stent, etc. What you do after the IVL is completely up to you and completely up to the characteristics of the lesion and the patient. Now I'm going to start going through some important trial data. This is the DISRUPT PAD3 study. It's an efficacy-driven, randomized controlled trial of calcified lesions. They looked at 300 patients across 45 hospitals worldwide. This was funded by Shockwave, but performed independently. And what they did is randomize moderately and severe calcified lesions that hadn't been treated before to either receive plain angioplasty, that's the PTA arm with 153 patients, or intravascular lithotripsy as the first mode of treatment. Then after that, people would receive a DCB, or they might receive a stent based on the angiogram and based on the choice of the operator. And people were then followed up at 30 days, 6 months, 1 year, and 2 years, and that was a standardized follow-up. This was powered to look at procedural success. And procedural success was defined as crossing the lesion, delivering your PTA or IVL with less than 30% flow limiting dissection. And in fact, they had a core lab and they looked at the pictures and made sure that the operators were reporting accordingly. They then reported primary patency at 12 months and reported all sorts of adverse events and reinterventions, as I said, at 6 months, 1 year, and 2 years follow-up. So there's long-term follow-up data from this RCT now. So what did they show? These are some of the most important figures from this trial for me. First of all, you don't have to inflate the balloon that you're using when you use IVL at a very high pressure in order to crack the calcium, which means that you're not going to cause severe dissections. Then they found a 75% reduction in provisional stent placement when IVL was used as a first strategy as opposed to plain balloon angioplasty. And there was a 70%, 69% in fact, reduction in the need for post-dilatation with IVL when it was used as the first strategy after crossing the lesion with a wire. The most important figure for me, a 77% reduction when using Shockwave IVL in dissections that would require a stent or some other form of treatment. So the bad types of dissections went down by 77%, which is quite an impressive reduction for this type of technology. So this is, for me, the more important randomized controlled trial, which shows you that clearly this is a safe, feasible technique, and it is associated with less stent use. It is associated with significantly less dissections in these severely calcified lesions. So then this is another study that we performed across the United Kingdom in a population who predominantly had CLTI and extreme calcification of their FEMPOP segment of their arteries. So we included any patient coming to 8 NHS hospital who had been chosen locally to receive IVL because they had very severe calcification. It was a prospective cohort study, and we look at people's patency after they had their IVL treatment. And we also did something very interesting. We looked at the composition of the plaque that we treated before and after using the IVL with a CT scan in order to look at whether indeed there are microfractures in the calcified plaque and look at whether there are any microdissections or microemboli that we might have missed. And we included 94 patients. As I said, 8 NHS hospitals, a very pragmatic real-world study. All patients had IVL as per instructions for use. And we recorded lots of procedural data and had a very tight schedule of follow-up at 30 days, 6 months with the duplex and the clinical examination. And don't forget that we did those CT scans of the lesion immediately before, as well as right after they had their IVL treatment. These are the sites that took part, and these are the baseline characteristics. And I want to stress the fact that predominantly we had people with tissue loss, rest pain, and multi-level disease and very advanced calcification. The immediate technical success rate, even though we were mostly treating CLTI with multi-level disease, was 100%. We had no ruptures, we had no embolic events during the procedures, we had no issues with the access sites. Now, because this was a population of patients that had predominantly CLTI and various other health problems, we had 4 deaths within 30 days, and they were due to heart failure and sepsis, so they were not related to the actual procedure. And the other results like amputation and major adverse cardiovascular events were very low, even though we were treating a predominantly CLTI population. Now, this is what we found in our CT sub-study, which is where we did the baseline CT angiograms in order to understand how the lesions looked like just before IVL, and then the after treatment CT scans where we looked at how the lesions looked immediately after we had used IVL. And to do that, as I said, we used CT angiograms. We reconstructed the plaque with TerraRecon, which is a type of software that allows you to do that. I'm sure most of you will have used it before. And we devised our own way of looking at the composition of the plaque. So what did we find? We found that almost everyone, 95% of patients, had at least one big fragment in the calcified part of the plaque, and in fact 81% had more than 3 microfragments. So indeed IVL does crack these severely calcified arteries. The super interesting finding was that there was a reduction within 72 hours of the overall calcium load within the plaque, even though this is not a debulking technology. So IVL somehow leads to modification of the plaque, even though it doesn't remove the calcium. Just by causing these microfragments within 3 days, the calcified component of the plaque has somehow remodeled. We also found that the median calcium load was reduced from 7.8 cubic centimeters, 5.4 cubic centimeters before and after. So again, we're seeing that IVL leads to remodeling of your very calcified plaque. Dissections and other complications were very low with no ruptures occurring. And that's not just based on the angiogram, this is based on the CT scan and based on the ultrasounds that we did. Now, I'm going to present a very interesting consensus that we did on vessel preparation for PAD, because when we talk about vessel prep, up until recently, we didn't even have a definition for what vessel prep means in peripheral artery disease. And IVL is all about preparing your artery for the subsequent treatment. And in fact, there have been lots and lots of papers on vessel prep in the last 7 or 8 years, but no one has tried to define what vessel prep means, where IVL stands within the vessel prep technology environment, and what the best use of vessel prep is. So we remain very confused about vessel prep. So why is the definition of vessel preparation? Vessel prep is now mentioned 79 times in the various ESVS guidelines, but no one in the European Society, the ESVS or any other global societies ever tried to define what vessel prep means. So this is what we tried to do in a global consensus project. So we ran this study globally, and we tried to define what vessel preparation means, what the aims are, explore the best clinical practice in this area, and identify where technologies like IVL and atherectomy sit, and then produce a position statement with some key opinions on exactly how we should best use IVL in the FEP-POP segment and other anatomical areas. We conducted a literature review, did a structured online survey, lots of interviews, and then we ran a few workshops internationally using the strobe criteria, the strobe guidance in order to gain Delphi consensus. These are the participants that took part, 103 experts with lots of experience in IVL and atherectomy from across specialties like vascular surgery, radiology, cardiology, etc. And this is what we found. There was almost 100% agreement that vessel preparation is the initial step in an endovascular procedure to facilitate subsequent interventions by modifying the lesion characteristics. So this is the globally accepted definition of vessel prep. The aims are luminal gain, change of compliance of the artery, reduction of the burden of calcium, better drug delivery and retention, reduction of procedural risks and complications, and therefore increase of technical success. Where did participants mostly use vessel preparation? The vast majority in the femoral popliteal segment. And this is where I think IVL actually makes a massive difference. Where do participants feel that we should use vessel preparation more? Again, the FEMPOP segment, superficial femoral artery and popliteal artery, because most of the participants were of the opinion that we should try and avoid putting stents in the distal SFA and across the popliteal artery. And this is where the vast majority of them said that IVL plays a very major role as the better or the best form of vessel preparation, especially in the superficial femoral artery and the popliteal artery, because you're less likely to embolize, less likely to dissect, you don't need a filter, and you're 77% less likely to need a stent. So what do we do with calcified lesions? In this global consensus exercise, there was more than 75% agreement that IVL should be the first-line vessel preparation procedure in patients who have got calcified aortic, iliac, common femoral, superficial femoral, or popliteal lesions. So for the FEMPOP segment, IVL should be the first-line vessel prep procedure if you've got lots of calcium, regardless of whether that's concentric calcium or eccentric calcium. For crural calcified lesions, there was no consensus reached, but I think this is where IVL is also gaining a bit of ground now, because we've now got the smaller catheters, and we've now got more experience in using IVL in the crural segment. Finally, there was quite a lot of resistance in terms of supporting the use of atherectomy in primary lesions. The vast majority of participants in this consensus exercise thought that for a primary calcified lesion, you should be using IVL. You could think about using atherectomy, like rotational atherectomy, in selected patients with highly calcified common femoral arteries, but across the SFA and the popliteal artery, IVL is the preferred option. In terms of definitive treatments, after using IVL in the FEMPOP segment, the vast majority found that a DCB, a drug-coated balloon, is probably the preferred treatment, especially in CLTI. And they supported the same in common femoral artery disease. For iliac arteries, especially for common iliac arteries, there wasn't 100% agreement, but most supported that covered stents might make sense if you do want to use something after the IVL is completed. I've got a couple of short cases. This is a lady who actually came to us about 3 or 4 times. This is the fourth time that she's having an angioplasty for what is essentially very short distance claudication. So she had this segment angioplasted before 3 times, then comes back and has got the circumferential calcium ring in her SFA and proximal popliteal artery. My colleagues, what they had done before, they had actually put a stent in the proximal SFA. So this is where the stent stopped. And you can see that the lady is now coming back with this type of disease and a restenosis and a near occlusion of part of the calcified SFA. So again, you can see where the stent stopped. We crossed the lesion intraluminally with an 014 wire, and then I'm placing an IVL catheter. This is the IVL catheter that you can see expanding here. This is 4 atmospheres without a balloon. And following that, this is the immediate result that you get. Thus, immediately after I've IVL'd the whole of that lesion, I've used IVL inside the stent as well, and then expanded the stent with a plain angioplasty balloon catheter to make sure that I get better expansion of the stent. And this is the completion angiogram after practically doing IVL. I delivered all of the energy cycles, and then after that, I used a DCB sized appropriately. Now, downgrading iliac disease, this is where I use lots and lots of IVL these days. We've now got the L6 catheter. I'm not sure whether this is available yet in India, but the L6 catheter gives you the chance to treat bigger diameters in one go. This is a case where, again, someone was treated before with an angioplasty of the distal external iliac artery because they're a young patient and we wanted to avoid using a stent, but the patient kept coming back with restenosis. She had a very calcified lesion in the distal external iliac artery. We used 4 cycles with the M5 plus, and we then deployed a Zilver uncovered stent at the distal external iliac artery. And we did all of this with CO2, and what you can see here is the end result. So what I'm trying to say here is that if you use IVL even in the external iliac artery, you can avoid using covered stents, which is cheaper, and also you can downgrade iliac disease and therefore not use massive covered stents. This is another iliac case. This is a very frail gentleman who couldn't even have an anesthetic, not even a spinal anesthetic, with very severe CLTI. So the gentleman could only undergo a quick 3 or 4 minute procedure under local anesthetic. So what we did here, the gentleman had severely, can you see this chunk of calcium there? He had severely calcified external iliac artery disease. So we went in very quickly with an IVL catheter and literally delivered a few cycles of energy, and we got a satisfactory result with very good flow. And what I want to showcase here is the fact that once you've used IVL, especially in big arteries, you don't need a perfect angiogram. The whole point behind using IVL is to slightly oversize your catheter by at least 10%. And then IVL practically, through those microfragments of the calcium, changes the compliance of the artery. You're not just looking for luminal gain. It's not a plain angioplasty. It's not a stent. You're changing the compliance and the behavior, if you like, of the artery during diastole and systole. So bear that in mind. As you can see here, this is not a perfect angiogram, but the patient was absolutely fine and healed their tissue loss, even just by doing this IVL procedure and then stretching the external iliac artery open to get a tiny bit of luminal gain after we changed the compliance of the artery. So bear that in mind. You're looking for better flow when you're using IVL and change of compliance. You're not necessarily looking for a perfect angiographic result. This was the end angiographic result in this case, and as I said, the patient had excellent flow in his common femoral artery after we performed this procedure, which literally took only 3 or 4 minutes under local anesthetic. Now, the common femoral artery is where I find the use of IVL incredibly helpful. This is an obese patient with several complications of diabetes. They could not have a general anesthetic. They had left-sided common femoral artery and SFA disease. The only procedure that could be offered was a local anesthetic procedure through puncture of the right common femoral artery. So we puncture the right common femoral artery, go up and over down to the left side, and then used IVL for the common femoral artery, the origin of the profunda, and the origin of the SFA. So you can see the occlusion of the SFA, which reconstituted at P2, so the second part of the popliteal artery, and you can see this stenosis, critical stenosis at the origin of the profunda artery. So we recanalized the whole length of the SFA up and over with an 014 system, and we only performed IVL. There's no stent here. We performed IVL of the common femoral artery, the distal external iliac, the origin of the profunda, and the whole length of the SFA. And this is the result that you can see after IVL and DCB. No stents, no filters, no emboli, no dissections, just coming up and over in order to treat those arteries. And that's the runoff. Increasingly, I am using IVL below the popliteal artery. This is a patient who had a distal AT occlusion and a long occlusion of the peroneal artery. The PT, the posterior tibial, was feeding the foot. They had several attempts at angioplasting these, and they kept restenosing. So what I did, we crossed the lesion and tried to address the PT, which was severely calcified. We only used a few cycles of IVL, and then we performed a high-pressure angioplasty, and that's the immediate result that you can see there, with no dissections, no emboli. Again, a 5-minute procedure to address a very calcified lesion. This is another case where I've used IVL in extremely calcified external iliac arteries. I've put this case up to show you that even in very, very extremely calcified arteries, you can get a good result. So this is how this artery looked like preoperatively. 84% of the artery is taken up by calcium, and we had a very good result just by using IVL in this case with no subsequent stenting. The key papers that I tell people to look at when it comes to use of IVL, especially in the FEP-POP segment, I've already covered the Disrupt PAD 3 RCT. There's a Disrupt PAD cohort study as well, where they followed up patients for up to a year, and you've got very favorable results in terms of patency, even in the common femoral artery. Then please download our VPAD consensus paper on the JEVT. This is the consensus paper about vessel preparation, and it gives you this global consensus of 103 experts, and it talks about both the FEMPOP and the iliac segment. And finally, you can read our shock study. I presented the results of those CT scans on the Journal of the Vascular Society of Great Britain and Ireland. All of these are free to download, or you can get in touch with me. This is my email there. You can also visit our Vascular Research UK website. But please do get in touch. I'm very happy to answer questions, and I'm very happy to share slides as well as literature on IVL. So that was me, really.
Thank you so much, sir. That was a very enlightening talk, and there are a lot of questions even popping in our mind. Like we can discuss it in the end of the forum. Chairpersons,
yeah,
Viru sir,
please go ahead. Yeah, please go ahead now. Yeah,
Raghuram sir. So there are a lot of questions which are popping in our mind, but I think we can continue with the talks right now. So, sir, Uh, Now, S.C. Mishra sir will be presenting a talk. Sir is a renowned faculty. He doesn't need any introduction as such. Sir was professor and HOD of the cardiology FMC Pune, and with multiple, like I think, pioneer in most of the things. So, sir will talk on the topic. Can IVL and DCB also be used in the calcified lesions in peripheral arterial disease? So this is a very interesting topic, particularly for the DCB, duct-coated balloons. So I'll hand over the mic to sir. Please continue, sir.
Yeah. So good evening, everybody. Parminder, can you help me with my slides, please? Shubham, please load the slides.
Yes, sir.
Kindly help me with the slides now. So, ladies and gentlemen, basically, I'm a cardiologist, and for a cardiologist, IVL has not been something very new. We have been using it for quite some time, and in fact, one of the guys who used to use IVL in the cardiac scenario way back somewhere around in the 2016 or so, 15, 16, we have been using it, and we were very impressed by the results in coronary. What is impressive is that with so much less risk to the vessels as compared to rotablation or the other modalities, we could get away with the plaque preparation in such a way that it became so much easier to position a stent and get the kind of lumen we wanted. In fact, it allowed us to modify the plaque in such a manner that the bed was prepared for an optimal placement of stent in coronaries. It was much easier for us to actually go and use it in the periphery because we had an eye for the kind of results we wanted to have before placing a stent in a coronary, the kind of beds we wanted to prepare. Unfortunately, you would be defeated in your purpose in case you want to prepare the same kind of bed in the lower limbs as the professor has brought out. Sometimes you need not look at a very good preparation of the vessel there than to get a rather practical results. Now, this case study which I'm talking about is Shubham. The next slide, please. So the this is regarding a gentleman who came from abroad to our country. He is I'm not taking his name. He's a great pop singer in his country and a renowned guy. He sings reggae and a chronic smoker, HIV positive, diabetic, hypertensive, and blind in one eye. And because of his smoking, he also had COPD. So he had a Rutherford 6 lesion in his right leg and a non-healing ulcer which needed to be addressed. And he was breathless when he came to us, and his echo findings showed us. Can we go to the next slide, please? His echo findings showed us that he had a 30% ejection fraction. So obviously, here is a gentleman who had a tremendous amount of atherosclerotic load, not only in the peripheral scenario, also in the coronary. So we also had the coronary, and the interesting case is this case becomes interesting because we did both the things, the coronary and the peripheral, in the same sitting. This gentleman had a normal left main. Go back, please. He had a normal previous slide. The LAD artery was a type 3 vessel which had 99% occlusion in the tightest part and was a mid segment, was thoroughly calcified and very bad, nasty looking lesion there. The LCX was a non-dominant, diffusely diseased, but had a TME3 flow, which the kind of flow that we talk about in coronaries. This TME3 flow is one of the highest types of flow. So he had a normal flow in LCX. RCA was a dominant lesion artery, but it had 100% proximal occlusion, although the distal part was getting filled by the left coronary injections. So here we had a patient who had a coronary artery disease, double vessel disease, 99% occlusion in the LAD, and RCA was a CTO, chronic total obstruction. So the recommended procedure here was a PTCA to LAD. And next slide, please. So next slide. So we use a guiding catheter and the usual 3.5 EBU and 6 French. We had the normal Fielder FC 014 wire, 180 centimeters, and we went from the left femoral artery. And we wanted to not disturb the right femoral artery, where we wanted to get in to do his lesion was in the right side. The Rutherford 6 was in his feet on the right side. So we did the IVUS, and the plaque burden was more than 60% in the artery. There was a pre-dilatation we did with 2.7 into 12 NC balloon at 18 ATM, prepared little place for us to be able to take the IVL balloon. It was not possible to carry the IVL balloon in this vessel, the kind of lesion he had. And with 30% of ejection fraction, we had to be very careful about the quantity of the contrast material we were going to use. So we used an IVL of 3.512, and with 3 cycles of 10 shocks each for plaque modification, we were able to get a very satisfactory result. And then we placed a stent of 3.526 drug-eluting stent, which was deployed at 10 ATM, and another one distally, because there appeared to be a little dissection at the edge of the stent. So we had to place another small stent distally at 11 ATM, and we had an excellent result. Can we have the next slide? Probably we have yeah. So here is the on the left side, you can see the artery, the LAD you can see at this particular juncture. Shubham, if you can show, is my cursor visible on the screen? Otherwise,
No,
you
sir.
can, yeah, is it not visible?
No, your cursor, we can't see
So
your
so
cursor.
so so this place where you find in the middle of the LAD, there is a lesion which is 99%. And next slide, this you can see here that 99% lesion in the AP view is seen here. We have crossed with we made some place for the IVL balloon, and after the IVL, next slide please. Next slide. This one, yeah. So this is the result. Since I'm not handling
Sir, you have an
yeah.
option called annotate. Can you click on it?
Where do you see that annotate thing? There is
Uh,
a
there will be a
share.
marker like icon. Let me see if
There
I
is a
can give you
hand,
an.
lower hand, upper hand, something. It's a raise hand, it says.
Yeah, yeah, I can see your raised hand. Can you mark? Can you click somewhere called annotate? It will be a
Where
symbol of a pen.
it will be a symbol of a pen. Okay. Um, no, I think I'm worried about spoiling whatever else is going on. So you
Okay, no
you
worries.
let it be however it is. So uh, next slide, next set of slides.
Yes, sir.
So this is the stent we position the stent. This is the proximal stent. We actually wanted to position the stent here itself and nothing else. Second slide in this. Good. So this is the deployment of the stent. No, go back, please. Go back.
Sorry.
Go back and show the third image in the same slide. Yeah. Third image here.
Yes.
Yeah. So after the deployment of the stent, we were not very happy with the result. Now the next panel of yeah. So as you can see, we are putting another stent here because there was a edge dissection which could be seen here. We positioned the second stent, and now show the third panel in this. Yeah, this is the second one. Now the next one. Yeah. Please go to the next set of panels then. So this is the final result of the artery. This is after we achieved this result, we went down and addressed the lower limbs. Now, please go ahead and the next image. So in the peripheral angiography, what we found was the right superficial femoral artery had a long calcified lesion with 90 to 99% stenosis along its length. The right popliteal artery showed stenotic lesion before the bifurcation. Right PTA showed a mild stenosis at the proximal origin, and the left SFA was actually 100% occluded. So here we had a patient who had a bilateral PAD, and the recommended procedure from our side was to do a PTA to the SFA of the affected side with IVL and use a drug-eluting balloon, and PTA with depth to the posterior tibial artery as well. So next slide, please. We use the same 3.5. We use the JR 3.5 7 French because the lesions were very difficult to cross from the bifurcation of the aorta, and I had to take a 7 French and a braided sheath till there. And the guide wire was 013 on which we took our the hardware. route was through left femoral artery because the lesion was on the right side. So we came onto the right side from there. We used the shockwave M5, and we used about 560 balloon to the IVL to do the 5 cycles of 30 shocks for the desired result. Can we see these slides now? Yeah, this one. Please show the first one. Please run the image.
Looks like an image.
Yeah, is it just an image? Okay, then play
Yes,
the
sir.
next one.
Yeah, these are videos.
Okay, so we have taken a 560 shockwave M5 and we have given multiple cycles through that, and you can see the calcification is visible on the screen itself without the contrast. And after the IVL was done, you could see a significant improvement. I wish we could show the artery before before the IVL was done. I think that slide is not there, not visible here. You can see at least this much. You can see here in the image. You can see this lesion, which is very tight lesion. Is just shown the cursor. They're very tight lesion, and then go ahead. Next panel. Next panel. Yeah. So show the second image of this. This is the and after that we have used a drug-eluting balloon, and with this drug-eluting balloon, this is the kind of result we have got on the next panel. So we used a 6-150 drug-eluting balloon at 7 ATM for 30 seconds, and the result was excellent. The artery looks very encouraging. Next slide. Next set of slides. And this is the final result on that artery, which was otherwise terrible looking earlier. And this is the distal part. If you could see, there is a lesion in the femoral in the popliteal part before it divides into the ATA and PTA. So there was issue about this part, and since this was a Rutherford 6, the lesion was deep in the feet and gangrenous. We had to do something about these also. So what we did is, here we did not do any IVL. We just went and crossed the lesion and did the PTA was addressed with the drug-eluting balloon of of a smaller size, the coronary drug-eluting balloons of Protege. The bigger one in SFA we used was it was not a Protege, it was Pearl form, a paclitaxel eluting DCB. And in the lower part here, we have used the Protege, which elutes paclitaxel. Can you show the final result, please? Oh no, go back, please. Previous
This is
one.
the final result, sir.
So this right panel you can show once again. So after the popliteal and the PTA were addressed, the results became satisfactory, and the patient has gone. Next slide. So what we want to try and project here is, in the same sitting, this gentleman received the treatment for his right lower limb peripheral arterial disease, and he had the angioplasty of his coronary with 30% ejection fraction of his heart. Now, the concept which we have been following in coronaries is something we have extended here also. Now, there is a concept of trying to use the drug-eluting balloon. There is a concept of stentless PCI now, and the idea is you use the stent if you must, and you should try to use drug-coated balloon if you can. So here also the same thing has applied in an SFA. The kind of movement that this artery is subjected to, the kind of movement that the limb and popliteal is subjected to, the stents are likely to be distorted. The chances of a possibility of a the stenosis in the stents is very high, and you can leave the artery quite physiological if you can achieve a very good result with either the IVL alone or with IVL and DCB. So the stent should, as far as possible, be one of the last resorts for us, and let the artery. It is much rather easier to go ahead and do a repeat balloon angioplasty with DCB maybe than to put a stent and achieve a total occlusion and not be able to cross it ever. So these are some of the cases which we keep doing, and this is one of the examples which I thought we'll present today. Thank you very much. I can take some questions in case there are any.
Thank you so much, sir. It was a wonderful case, and definitely the present scenario is like leave nothing behind as far as peripheral is concerned. Rightly said. And chairpersons and the esteemed panelists, can we go forward with the next talk, or
Yeah.
we'll have questions
No,
right now?
no, please go ahead with the next talk. I think we'll have the question answers in the end.
Sure, sir. So
Yeah.
next we have with us our very expert vascular specialist, Dr. Pavan from Esther CMI Hospital. He is quite experienced in peripheral arterial disease, DVT care, and
Am I audible, sir?
Yeah, we
Yes,
can
yes,
hear
you're
you.
audible, sir. Doctor.
so Mike, handed over to Dr. Pavan, please.
A very good evening to all the esteemed faculty. I am Dr. Pavan, consultant vascular surgeon working in Aster CMI Hospital. So I'll just take you through the technology. So and what the challenges we encounter with calcium. So many challenges exist when you treat calcium with uh, uh, possible complications like dissections, perforations, distal embolization when you deal with this calcium. And also, we look at calcium in these arteries when we are looking to do other procedures like an EVAR. So, calcium here is again a problem in the iliac arteries. So, stent getting crushed or stent fractures are also quite common when you are dealing with calcified arteries and vessel recoil. So, this is where IVL is a very helpful method of treatment. So, as already been told, it delivers catheter and inflates it to a low pressure, generates sonic pressure waves using lithotripsy to crack the calcium and safely expand the vessel. So IVL delivers 1 pulse per second at an effective pressure of around 50 atmospheres, and the balloon can be maintained at a low inflation pressure, and it fractures both superficial and deep calcium. So it has a very unique mechanism of action wherein you have high speed sonic pressure waves created safely inside an integrated balloon. So, firstly, you will find that there is unfocused lithotripsy energy which is created at the emitters, which are contained in a fluid filled coupler. So, this electrical energy is then delivered to the emitter, initiating
Sorry
the
to
vapor.
interrupt, doctor, but your slides are not moving. We can only see your first page.
Oh, okay. 1 minute, sir. Now is it visible, sir?
Can
Visible,
you
but
make
it's
it the
not in
full
the
screen
slideshow mode. Can you please make it in the
Yes, sir.
slideshow mode?
Thank you.
Yeah,
slideshow?
now is
Yes,
it?
doctor. Yes.
Yeah, sure. So again, mechanism of action. So the electrical energy is delivered to the emitter, initiating the vapor bubble, which expands and collapses, creating sonic pressure waves. And coming to the shockwave IVL system, it is a predictably safe device. It can safely modify calcium while significantly reducing the risk of complications to make the procedure more predictable and efficient. So, and
Uh,
it is also distinctly
sorry, sorry, Dr.
intuitive.
Pavan. I think it's not working, or is it only I cannot see it working? Oh, okay.
Are you able to see the slideshow now, sir?
Not the slideshow. Actually, it's in the open mode. Can you make it the slideshow?
Yeah,
But
it's
otherwise,
not,
it's okay.
it's not in the slideshow mode. It's in the still the slide individual slide viewer
One more.
mode.
You have
Can
to
you just click on that
go down.
slideshow thing? Yeah. Go down and click on the slideshow button.
You can click window plus F5 for
Mr.
that, sir.
Shubham, can you please start?
Window plus F5.
Window plus F.
Come again, doctor. I can't hear you. Dr. Prashant, you were saying something. Tell me.
No, I was just asking you to help him out. You
Yeah,
already
please,
helped him out.
Dr. Pavan, can you click on window and F5? It will take you to a full screen mode.
Okay. So, fine.
Or else there is a presentation mode on the bottom where you can see comment. Yeah, on the extreme right,
Yes, sir.
uh, just on the left of 83%. Just on the left of 83%, there is an icon. Just
One
click on
minute.
it, doctor.
I'll just stop sharing and then share again.
Sure, doctor.
Uh, Meanwhile, a
Now,
question for yeah. Okay.
now, sir.
Ju-
Still not the site
just
support,
click
but yeah,
on, yes, just click on this icon,
Yeah.
doctor, where you were. Yes, just here. Click on it.
Yeah. Now.
Yes, yes,
yeah. Now
perfect.
it's
Thank you.
continue.
Okay.
Now it's okay.
So that was about the technology of IVL. I'll just present one case which we have done. So we had a 72-year-old male, was a diabetic, neck smoker, an IHT who underwent PTC and DS 1 month prior to our procedure. So he came in with complaints of bilateral lower limb lifestyle limiting claudication. So the MR angiogram which we had done showed heavily calcified CFA plaques, eccentric plaques, causing near total occlusion on the left side and around 50% stenosis on the right. So the symptoms were more on the left side, so we decided to address that first. So the procedure we had planned was to go transbrachially from the left brachial artery, do a left lower limb angiogram, IVL with a DCB or a stent. So this was the initial angiogram which we did. Just one moment, sir. The video is not playing.
So keep the images. You can show some. That should be fine.
Just give me 1 minute, sir.
Uh, Meanwhile, while Dr. Pawan is correcting, Professor Sarasin has to leave. So we can have few question answers with him right now. Sir, one question is from my side. Are you there, sir?
Yes.
Hello. Yeah. So, like a very common situation, quite common situations, is like we have atheromatous complete or chronic total occlusion. Along with that, we have a whole calcified vessel or calcified atherosclerotic vessels. So, those are the cases where ideally we should have both the entities with us. Like we should have a rotarex or atherectomy, plus we should have a IVL. So, what is your take on those situations? Like you go with both the things, or any other give anything different?
Can you repeat your question, please? Sorry.
Yeah.
Did it refer specifically to the because I heard you say iliac at some point.
No, not iliac. Mostly about the let it be iliac also, but also about the common femoral arteries or superficial femoral arteries, SFA most
Yeah.
commonly. The patient usually many a time present with a calcified artery, plus
Yeah.
for a good length of segment, it is a chronic total occlusion, be it a
Yeah.
thrombus occlusion or be it a chronic thrombus occlusion, whatever it is, but it's complete occlusion. So those are the cases where ideally we should have both the entities. Like for the atheromatous or calcified arteriosclerotic part, we can go for IVL, or for the atheromatous occlusion, we'll have to go for atherectomy. These two are different entities altogether. So, what is your take on these type of cases? Like in one of your slides, you had mentioned about
Yeah.
the atherectomy also.
Yeah, that's a very good question. And I think the most realistic answer to your question is to take it on a case by case basis. So you might remember I said that it's better to cross within the lumen. Now, this is especially the case for the common femoral artery, because I think if you start crossing in a heavily calcified, completely occluded common femoral artery in a subintimal plane, you will probably jeopardize the profunda origin. So that's the first thing to consider. So if you've crossed in a very calcified common femoral artery inside the lumen, I think for me these days, for eccentric calcium and even eccentric calcium, IVL is the first line. So common femoral, I've crossed intraluminally after lots of attempts. I will use IVL and probably not atherectomy. Now, when do I use directional atherectomy or OAS, as in orbital atherectomy? If I really want to debulk, then you probably have to use orbital or directional atherectomy. So that's where I see those technologies still having a role to play. So you want to debulk, you have to use atherectomy. If you think you can get away without debulking, then I would preferentially use IVL. But I don't necessarily feel that if you've got an occlusion of the common femoral or the distal external iliac, that you always need debulking. You need to persevere, try and cross in the lumen, and then upsize your IVL catheter by at least 10 to 20%, give loads of cycles of treatment, and invariably you'll get a good result. Then you can perform your DCB, and you might even be able to avoid needing a stent, even in the external iliac artery, and most definitely in the common femoral artery. For me, for the common femoral artery, I'm trying to avoid stenting as much as I can. This is why, preferentially, I'm trying to stay inside the lumen and use IVL. I hope I've addressed your question.
Yes, sir. I'll ask Virender sir and Raghuram sir.
Yeah, because
Kindly, if we have any questions for sir and for other faculties also, like
yeah,
if you have any questions for the sir or any part of the discussion.
yeah. So I'd just like to ask the professor a couple of quick questions since I think
Yeah.
he needs to leave. One is, if I'm to understand correctly, uh, uh, to use an atherectomy device safely, you need to ensure that you are in the true lumen and not in the subintimal space.
Absolutely, yeah.
Right. So if I have to see the perceived benefit of an IVL over an atherectomy, because there has been kind of a wave of IVLs initially in India, and then there was absolutely a bombardment of atherectomy devices, and somewhere the IVL got lost.
Yeah.
So if I have to think of or maybe share the perceived benefits of an IVL, then
Yeah.
would it be right on my part to say that if I'm not sure whether I'm in the true lumen or the false lumen, because sometimes you may be false lumen to true lumen to false lumen to true lumen, because if you don't
Yes.
if you don't use an IVUS, sometimes you don't know from where to where you've gone into the true lumen. So would it be right to say that probably if you're not safe, if you're not sure you are in the true lumen, absolutely, then probably an IVL is safer than an atherectomy device.
I completely agree. The other way to look at it, as in whether you're inside or outside the true lumen, you can do a number of projections. So take 2 or 3 or 4 different projections, and you can see the course of your wire. Even if you haven't got IVUS in the superficial arteries, like the common femoral, then you can use extravascular ultrasound. You can do a duplex on the table, can't you? And if you've got doubts about where exactly you are, you can use your duplex probe and tell where exactly the wire is crossing. But most definitely, IVL is safe to use intraluminal and subintimal, and this is most definitely a benefit over atherectomy. The other benefit over atherectomy is that you're less likely to dissect, you do not embolize with IVL, and you don't need the filter. So these are the benefits that I see.
Yeah. Perfect. So the other thing I'd like to ask from you, from your practice, uh, with the results of the Basel 3 trial, what's
Yeah,
your take now on the role of DCBs after these procedures? Have you
yeah,
changed your practice in terms of the usage of DCBs?
yeah. Thanks. So DCB for me remains important, especially in CLTI, because I'm trying to keep those arteries open for long enough so that the patients can heal their ulcer. And then I don't have this issue about increased mortality in CLTI because the paclitaxel devices have not shown an increased chance of mortality really if you have got CLTI. Now, overall in the UK, I would say that indeed the use of paclitaxel-based devices has dropped. I still use them for CLTI, like I said, but I've also started using more and more sirolimus or everolimus-based therapies. I think you've got excellent access to all the limus-based balloons in India. So my use of DCBs is now more limus-based, but I'm still using them, especially in CLTI.
Yeah, but I mean, we have a large, what should I call it, a school of thought in India, where who are very aggressive with POBA. And
Yeah.
if you see the results of the Basel 3, it actually justifies the use of POBA because the results in the SFA have not been shown to be superior in terms of patency with the use of
Yeah.
DCBs.
Mind you, Basel 3,
Yeah.
The vast majority of the people in Basel 3 were having older generation devices in terms of the DCBs and DSs used. And please be aware of the fact that vessel preparation was not fully taken into account in Basel 3. And by the way, I've randomized 98 patients in Basel 3. So it's not like I do not believe the study. I really believe in those big, properly conducted RCTs, but they were conducted a number of years ago. And now I've got a slightly different population of patients that I'm treating. And I honestly don't feel that POBA just by itself is as good as using proper vessel preparation and subsequent appropriate therapies properly sized with adequate follow-up and adequate pharmacotherapy. Because we're just inundated with re-interventions for CLTI and with amputations. And I think we need to do our best to use those new technologies because they have got some efficacy data behind them end of the day.
Yeah. Yeah, thanks.
Yeah, Dr. Pavan, I can share your PPT.
Yes, Shubham,
Shall
please
I?
go ahead.
Yeah.
There are some
Yeah,
issues
sure,
with
sure,
the.
sure.
I think I'll go to the case.
Sure,
Let
sure,
me
doctor.
know.
Let me just please confirm. You can see? Yeah,
No.
Yeah.
just a second. Six. Yeah,
Yeah, next slide. Yeah, the
yeah,
first video on the left. So the initial angiogram here showed a heavily calcified CFA with near total occlusion. So we crossed the lesion with the 014 wire intraluminally. Next slide. So post crossing the wire, crossing the lesion, we did a pre-dilatation with the 4 balloon just to take our device across, and then this is the IVL being carried out with a 6 into 60 balloon here. So we delivered a total of 300 pulses to the CFA. Next slide. So this was a check angiogram which we did. So showing good luminal gain, but with still residual calcium there. So again, this might be a controversial thing to do here, but we went ahead and placed a vasculomimetic stent here, a Supera 6.5 mm stent. Next slide.
Yeah.
So post deployment, yeah, the last slide. So this was the final angiogram, which we found to be satisfactory. So any comments on this, sir? I wanted to know if that was the right thing to be done, or because we found that the calcium there was quite dense and we needed something with a good radial force to keep it open. So we plan to go ahead and deploy the Supera there.
May I ask a quick question? Generally, how do you guys view success after IVL? Do you remember I briefly said that for me, an angiogram is not the best way to look at success after I've delivered IVL, because it's not angioplasty at the end of the day. It modifies how the artery wall behaves. So invariably, what I will do, I will take out, first of all, I'll look for pulses, right? But also use duplex and see whether the waveform has changed if I'm not that happy with the angiogram. And then I might just do a plain angioplasty and recheck. And again, if I'm happy with waveforms, I might even leave it to that. And I know that many colleagues in Europe increasingly do that after IVL now. As we've become more and more accustomed to how it works, we're more confident just leaving things as they are without stents. So I'm not that worried about radial force after you've used IVL.
In fact, I would like to take this point a little further. Drawing from our experience in coronary, we have realized and we have overcome that fear of recoil and closure of the vessel subsequently.
Yeah.
After we have prepared with IVL and just done a drug-coated balloon treatment to the vessel, it gives a fairly good result and for a very long time.
Yeah.
And it leaves you with a chance to do it again should it close or recoil again in future, because once you put a stent, you have committed that lesion to the kind of the outcomes where you may be left with very little chances.
I fully agree with you. I think we've got the exact same experience in PAD. The recoil is less, the artery behaves in a different way. I think it's a plaque modification therapy of some description. It's not really an angioplasty. So bear that in mind. And I think, you might be surprised with your outcomes.
Yeah, I think
so we are actually having a very huge number of cardiologists now talking about there are conferences occurring on stentless PCI. This was never imagined. In fact, try and imagine that you do a treatment to a vessel and leave it physiological at the end of the day.
Yeah, agreed.
So stent if you must, and DCB if you can.
That's a very good phrase. I'll borrow it. Stent if you must, DCB if you can.
If you can.
Yeah.
Thank you, sir.
That's all. Thank you. I'll unshare the slide. Thank you, Dr. Pavan, for taking out schedule. Thank you so much.
Are we having other speakers?
Yes, Dr. Zubair is up next.
So we can go forward. Yeah.
Yes.
So Dr. Pavan is finished with the case?
Yes, sir.
I think it was half done or something, but it's okay. Now, next we have a very dear friend of mine, Dr. Zubair. So he is like internationally acclaimed. Like he has multiple presentations, multiple faculty and speaking, many of which were with me also. So he'll be presenting on complex decalcification in the peripheral arterial diseases. Over to you, Dr. Zubair.
Dr. Zubair, we can partially see your screen, but we are unable to hear you.
Zubair,
Can you hear me now? Am I
हाँ
Yeah,
audible?
सुन
yeah.
सुन रहा है जुबैर बोलो हेलो
Yeah.
यस
And
जुबैर
thank
कंटिन्यू
you, Prashant sir, for the kind introduction. Can you see my screen?
Yes, sir. It is visible.
So I'll be talking about one of our first case in Central India. We did with IVL. So a 57-year-old male, diabetic chronic smoker, presented with non-healing wound in the left foot. We did a CT angiogram, which showed diffusely calcified vessels, and left SFA and popliteal was occluded.
सॉरी जुबैर कैन यू स्क्रीन वो नहीं दिख रहा है मतलब कैन यू डू अ स्लाइड शो
Okay. Can you see it now?
not in the
You can
slideshow
do,
mode like you
yeah,
know
you're not in the slideshow mode, so you will have to manually keep changing the slides all the time.
You have to go down on the right panel and then do it.
Yeah,
Now you can see my screen.
we still see the same slide.
Dr. Zubair is a tech guy. How come we are not able to see your slideshow, Zubair?
Just a second.
Shubham, you have sir slides with you?
No, unfortunately not.
Okay.
Dr. Zubair,
So
can I share my number and you can share it to me via WhatsApp, email, or whatever suits you?
I think I have some videos in that. Can you
Or
see the
anyways,
screen?
there's a button on right where you can see comments,
Yeah.
third button. Yes.
Now you can see my screen.
It's not full screen, doctor.
But you can scroll,
Where the
Dr. Zubair. If you want, you can scroll the slides and you can show us the videos.
yeah, that's
Yes.
And
what
you can
probably.
dictate the case.
Yeah.
Dictate the case.
Also, in the interest of time, then otherwise.
Yeah,
Now you
that
can
should be
see
fine.
my slides.
Yeah. We can partially visualize it. You can continue.
One minute. Now you can see.
Zubair, you can continue. We can partially see your slides.
Okay. Just a second. Yes. Now you can see the. Now you can see it fully.
No, you're still on the slide only.
Okay. Actually, I shared it. Okay. So can you see it partially also?
Yeah, please go ahead. You
Yeah.
can keep describing,
So
and I
this
think
was
we'll.
the presented with a wound. This is the pre-image. We did. We crossed it with the DNA series. Did a plasty. Did IVL. And this is how the IVL works. Already, previous speaker has talked about it. So this was the final shoot we got post IVL, and this was the flow in the peroneal and PTA. On follow-up, the wound healed completely post 1 month. Thank you so much. Any questions?
Okay. Yeah, none for the now. We can have a discussion in the later part. So next we have with us Dr. Anoop. So Dr. Anoop.
Dr. Anoop is not there. He had a mishap, so he had to rush in.
Okay, so Abhishek is there?
Yes, Dr. Abhishek is here.
Yeah, I'm here.
Yeah. So the next to us is my dear friend, Dr. Abhishek Bansal. So he's in Akash Healthcare Super Specialty Hospital, and definitely I think very less is written about him. So globally, multiple awards, SIR fellowships, young IR leader, he's everything which you can think of. So right now, next he'll be presenting about the intravascular lithotripsy in PAD. So over to you, Abhishek.
Thank you, Dr. Prashant. I think it's an honor to be here, and we share a friendship for long, and always good to learn from you. And without taking further ado, I think I am stopping in between everybody and their dinners. So I'm going to share a few cases that we performed, and it will just take your opinion. And if anybody wants to add on to it something, I'll be happy to share and further discuss. I take you back to this first image. I think we all know how precious and how important this image was. And what is important is that uh, 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 read this, visualize, but do not try to fix it. I think that's all of us. All of us have faced that in our careers, where we have seen that we got referrals and all those things, and we've been more thought of as key something. If somebody is doing something, maybe this guy is crazy. I don't know what he's trying to do. He or she is doing to do. But I think Dr. Daughter inspires us all, and I think that's what he said way back in 1963, that the catheter can be more than a tool for passive means of diagnostic observation. And I think used with imagination, it can become an important surgical instrument. And that's what we all have are been doing in vascular surgery, be it interventional radiology, be it interventional cardiology. I think it's our imagination that's holding us back in achieving more and more and better results with better and better techniques. And to that extent, IVL has something that has really changed how these calcified lesions are being managed. And we all know about this task 2 classification, and how I'm going to skip the type A1, B1s, but focus on the type D ones, right? These were the ones who who were kind of a no for endovascular, but how all these things have changed. So starting from the iliac ones, we know that the heavily calcified plaque, it negatively impacts the procedural success and long-term durability, especially in iliacs. And these are the vessels that are higher risk of embolization, dissection, and perforation. Mind you, we all have seen perforations, and it can be very unforgiving in the iliac anatomy. Standard balloon angioplasty often requires high pressure, which may further increase dissections. We have all talked about this. And especially in iliacs, there's no scaffolding. And if it ruptures, if it bleeds, it can be fatal because of retroperitoneal bleeding. Uh, we know that the technicalities of the anatomy, both the vessels are dividing into aortic bifurcation, and sometimes we need to do kissing balloon, kissing stent, and all those things that increase the complexity. Recoil is very important, and atherectomy is very out of the box. We have seen some case reports where atherectomy has been performed in iliacs, but generally traditionally it's not recommended to be used in the iliacs. Moving on to our cases, this is the first case that we wanted to show you. You can see how pretty badly calcified the iliacs are, and especially the right one. And this was the CT angio. And you will see that heavily calcified, almost no flow in this patient. And we did, and this is the pre-procedure angiogram. And you can see heavily calcified vessels and practically no flow in the right side. So we did a IVL. Obviously, we didn't use two IVL balloons, but we used a single balloon, and from the opposite side we used a balloon as a parallel kissing sort of a thing, so that there's no plaque shifting. And that's the post procedure angio. And you can see such a good flow. Obviously, there's certain residual stenosis, but at least that flow has been established. And I think our aim was, to be honest, in iliacs, and to do away without placing a stent is something that I feel is pretty good, because it saves your access for the future intervention, especially if you want to go below the infrainguinal area. Otherwise, for with a kissing stent, it becomes very difficult to really intervene at a later date for any disease that's below the inguinal region. Moving on to the next case. Uh, I'm sorry, this video is not playing. But the image that I showed you initially was this. This is the VRT, and if you can see that pretty calcified and almost near total occlusion in this patient as well. And again, we wanted to do an IVL for this. Mind you, we had counseled this patient that we'll try with the IVL and a DCB angioplasty and try to avoid stents. But if there was significant recoil, we had counseled the patient for stenting as well. And that's our IVL balloon. And okay, I'm sorry for this media glitch. Anyway, these were just angios that we how we crossed and we placed balloons and from both the sides and crossover thing. And yes, this is static image. That's what is a pre-procedure look, and you can see pretty amazing kind of response in terms of if you will see it compared with the pre and post IVL and a DCB. Again, could totally avoid stenting in this patient and put him on anticoagulants, antiplatelets rather, dual antiplatelets, and a low dose Xarelto 2.5 as per the latest trial. Uh, Professor has talked about the Disrupt PAD 3 study that has already been talked about. What I would want you to highlight is that, especially in ILEX subset group, if you would see this group, there was 0% dissection, 0% perforation, and 0% embolization in the IVL subset of the ILEX subset. And we talk about the calcium modification. If you will look at that. So diameter stenosis reduced from almost 81% to 24%. And if you look at the ILEX subset from 76% to 21%, and this was something significant, which is very difficult to achieve with just a plain POBA balloon angioplasty, especially in iliacs. If you talk about in terms of diameter stenosis from the final results, it was just 12% out of a group of 200 patients. So that was again very important. And again, look at the results: zero perforation, zero dissections, especially the type D to F, and no slow flow, no reflow. So moving on to, we know that ILEX is something that is a special thing, but femoral is something that has been a lot of options are there, atherectomies, IVLs, and that's done pretty routinely. However, when we move to the below the knee, that's considered the graveyard of angioplasty. And this is just the AI from Google. It will tell you all sorts of problems, technical failure, elastic recoil, restenosis, repeat procedures, heavy calcification. We know that they have long CTOs, ambiguous anatomy, and poor distal targets. So this is something that is very important, and that is why I think majority of the doctors are shying away from tackling BTK. But yes, it is something that is very important. And as was shown in the previous case, where a patient had a Rutherford 6, until you're going to open up the BTK vessels, you will not be able to open up the angiosome. So that may be a problem for those patients. And again, for task D lesions, again, traditionally, when there was limited options, I think IVL is something that is really changed. Even as per the latest guidelines from ACC, AHA, they talked about bypass, but I think that has been changed a lot with the IVL. And we have the Disrupt PAD BTK2 study. And again, 250 patients, 305 lesions. And the mean target length was almost, if you will see this, 76 millimeters, so almost 76 plus 60. So more than, on an average, 10 centimeter long lesions. And the diameter stenosis was almost 78% a mean. So that is something pretty important. And 85% had moderate to severe calcification, which we see all in our day-to-day patients and especially the diabetics. And if you look at the mean lesional diameter from zero point 0.7 to 2.4 post IVL and angioplasty, and stenosis reduction from 78% to 26%. So that was something very satisfying. And look at the complication rates again, like what we saw in the ILEX subgroup, even in the BTA group, zero thrombus, no reflow, no spasm, distal emboli zero, and almost all other perforations were less in terms of what you would see with a normal POVA angioplasty, that it outperforms POVA any day in terms of safety and avoiding all these complications. Uh, this is again how the Rutherford category lesions healed from pre-procedure to post-procedure after IVL and angioplasty for these patients. And we know that with this background of data and in our experience also, we have almost done now more than 10 such patients for BTK IVL. And in all those patients, we have been able to achieve very good response, very good results, and come out without placing a stents and led to the healing of those patients. So this is another patient. You can see heavily calcified vessels, literally any hardly any flow in the peroneal and the PTA, some bit of flow in the ATA. That's the pre-IVL angiogram. You see hardly any flow below the mid calf in the peroneal and the PTA, and there was hardly any flow in the foot. I think this is the video that's not playing. That was a foot video. And that's how we have done IVL both in the ET and the PTA for this patient. And this is the post IVL angiogram. A bit of dissection definitely seen here, but it was not flow limiting. We didn't want to intervene. We put the patient on dual antiplatelets, and that was a foot run that showed beautiful flow in the foot, which was hardly seen prior to the procedure. So it is very, very important that even in BTK patients with heavily calcified vessels, we can use this modality with very good results. And we know that calcium increases complications, reduces optimal angioplasty results, and stent apposition. Eye-leg bifurcation stenting limits future treatment options. And not just eye-legs, I think especially in femoral popliteal, I think we are all moving towards leave nothing behind, right? Do not leave a stent behind, because it's easy to place it now, but when you go back, re-intervene, then it's a very, very problematic thing for these patients. IVL, we have seen in a number of slides, safely fractures calcium, improving or eliminating stent place as well. And we've had a wonderful results with our patients where we have been able to totally avoid stents in all these patients. It facilitates lesion expansion and adjunctive therapies. And as shown, both ILEX to BTK, outstanding safety profile. I think that was very, very important. And that's it from my side. This is again this video was showing the tick 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 sound of the IVL, which we really love, and I think that's a blessing in disguise for all our patients. Thank you so much.
Thank you so much, Dr. Abhishek. And so this concludes our present CME webinar. Now the house is open for the questions and further proceedings.
Any questions, any faculty?
Yeah,
Dr. Agram Shekhar, sir, if in case.
I just have, I mean, more than a question and observation. I'd like to appreciate really the stress that Dr. Bansal has made, because, you know, a bulk of the work that I do is diabetic foot related, and a lot of it is BTK disease. Now, one thing is for sure, as per the current data, you know, there is no role for DEBs in BTK disease right now. There is no data to show that, you know, that DEBs really work as of today in BTK disease. So if you have a heavily calcified vessel, and we see a lot of these, and, you know, if you see the data regarding IVLs where there is very little dissection and, you know, distal embolization on all those things which we sometimes we deal with single vessel runoffs. I think IVL, I've had an excellent result with that. You know, very often we are just dealing with one single vessel. You know, we talk about angiosomes, but very often the wound is somewhere and the vessel that is surviving is just one single peroneal or a single ATA. In that, you know, to do a kind of a atherectomy, get a slow flow or get distal embolization or, you know, dissections would be a disaster. So I find especially in our type of patients, diabetics, heavily calcified, single vessel runoff, I find IVL to be a fantastic tool. So that's my experience. I'm sure most of you who are doing BTK work will agree that once in a while, you know, we get into a fix where we have these single vessel calcified vessels, and you know, we are very tempted to be pushed into using these newer atherectomy devices, and I mean, I've seen quite a few disasters with them.
Dr.
Agreed,
Shekhar,
sir. And I think we are all.
Yeah.
Please go ahead. I just wanted to add that we're waiting eagerly for the E8, sir, because I think that will really make our life easier, the longer balloon, because I think that's where we struggle in BTK is that those smaller length balloons, really we need to have two, probably sometimes IVL balloons, which really increases the cost. So once we have E8, I think more and more acceptability of this balloon would be there for the population.
Yeah.
Dr. Mishra, sir, your last comments.
I am very impressed with the different kind of talks that we've had today. A lot of these guys are actually vascular people, and some of them are interventional radiologists. In fact, I have learned more than I have been able to talk about. All I am concerned about is that the below knee issues are always, whether surgery or stenting or DCB, is not as satisfying as it is above knee. But the IVL, as I can understand from these people who probably are dealing with more of it, is turning out to be a panacea of sorts, where you can do very little else when it is a calcified vessel. The only thing comes up is when you have a vessel which is narrowed, looks very sick, and is not calcified. Then probably the arena is open for anything else that you could use. But whatever you may use, if it is not a calcified vessel, it is better not to leave something behind, as somebody mentioned. The concept is not to leave anything behind. So if at all in the non-calcified but diseased vessels which are not showing a very good flow, it may still be a very good option to just get away by doing a DCB and not leave a stent there for any future disaster. I, for one, have understood one thing. Some of the concepts of lithotripsy I remember very well in 2016, Parminder, with you and the team there in Command Hospital, Bangalore, where I had done the first rotatripsy, wherein that 70 years old lady, we had to perform a rota followed by the lithotripsy, and we had a very good bifurcation angioplasty result in the left main. There it's a different ball game, but here down here a rotablation I think is very disastrous in case it the kind of the distal embolizations and things of that kind, and in case you land up in any complication there, then I'm not sure. God only save you. I mean, the covered stents and whatnot you may put, but probably the results are not as good as it can happen in coronary. Even there, if you fail, you meet with a disaster. Rotablation, probably IVL is an upgrade from the possibility and need for a rotablation. I look at it as one of those things. So for me, it was a great learning listening to these people, and maybe I feel happy that I am probably following most of what these guys are talking about. It's very great. And the professor who spoke about, I think he was talking about filters, and I was very impressed. He was talking about filters in the lower limb. Probably he's talking about carotids and all that. We have not thought about. I would be impressed if somebody is using any filters in the lower limb, particularly when you're doing any procedures. Or is there any role for it?
Oh yes, there is a lot of role. In fact, the most of these atherectomy devices go with the advisory that you should use a filter.
Okay,
So
okay.
the issue is that the filter, putting in the filter, pulling out the filter itself has its complications, and
Yes.
it significantly adds to the cost. But
Mhm.
but the role of filter is definitely there. I mean, say for instance, in an SFA, if you're
Hmm.
working with one of those modern atherectomy devices, there's quite
Yeah,
a lot of muck that goes downstream. So you do
I can
need to
guess
use
so.
a filter.
Yeah.
You do need to use a filter.
Okay. Yeah. Thank you so much. Thank you so very much. Parminder, I'm really impressed by the extent of the academic feast you people had lined up for the evening today. And thank you very much from my side for the excellent presentation that the speakers have had.
Thank you very much, sir. It's really been an enlightening, a very enlightening discussion, I think, these last 2.5 hours. We thank you all, in fact, for granting us your time, precious time, invaluable time. I can see some of you all scrubbed up also. Dr. Shauryan was scrubbed up, went into a case. So really, really, very, very grateful. Thanks to all of you to give us this particular time to have such discussions. And of course, this is what keeps us moving. The momentum which is there is in the academic excellence, and that is what we firmly believe in, and that is why master classes are for. So we will definitely keep on doing this with your blessings as well as your support to make sure that we definitely do not flag off on the academic excellence and research. So with this, we call it off a day, sign it off, and thank you very much, Raghuram Shekhar sir.
Thank you.
You've been there throughout the evening and contributed so much. Dr. Mishra sir, you've been contributed both to the coronary and the peripherals. Dr. Abhishek Bansal sir, I'm sure that you're going to be seeing a lot of IVL new cases from you in the ongoing seminars. Dr. Pavan, of course, thank you very much for being there with us, although little technical glitches, but I'm sure that probably in the oncoming sessions, we would be able to have many more cases and see many more good outcomes, with Shockwave IVL. And of course, thanks to my entire team over here, with Shubham, with Nishant, with Anil. They've all been there working in the background. And now, of course, it's time to call it a day, because I'm sure I would like to keep it away from your family members and to whatever evening that you would like to spend. Support. And thank you very much once again from all of us at Translivina. And wish
Thank you
you
so much.
Thank you.
Thank you.
Aruva
Thank you.
and goodbye.
Thank you.
Thank
Thank you. Good
you so
night.
much, sir.
Thank you very much, sir. Thank you.
Thank you.